Many thanks and good morning to all. So today I'll be telling you about a study project aiming at assessing cholera transmission in endemic areas following mass preventive OCV campaigns. As we said, cholera today is going through a resurgence. It reappears in various parts of the world, and in some parts of the world it's endemic. One of the control strategies, of course, is the oral vaccine against cholera, which is also recommended for use in endemic areas. This approach, based on preventive campaigns against cholera, is relatively new. That's why there are still pending questions to be investigated, particularly the efficacy of this type of campaign, the evolution of the alerts and reporting systems following the campaigns, how long can it work, and the impact on the dynamics of transmission. At Epicentre, we initiated this study to evaluate those impacts. The study took place in DRC, in Goma, an urban site, and Bukama, a rural area. This study consisted in three main activities. First, clinical surveillance in all the centers and cholera treatment units in both sites. We included all the suspected cases, and those cases were formally confirmed with a laboratory analysis. We also did surveys to assess the vaccine coverage, and with that we could follow the evolutions of the trends over time or evaluate the vaccine performance. Second activity, a seroprevalence survey on both sites with independent sampling in the community for serologic analysis, the aim being to estimate the immunity level in the general population and the evolution over time. The third pillar is a follow-up over time of some positive patients that we identified either based on clinical surveillance or seroprevalence surveys. We also collect environmental samples when we do home visits, and this activity allows us to evaluate the duration of excretion of cholera, as well as estimating the occurrence of asymptomatic cases and the transmission vectors in the household. Those are the preliminary results from surveillance and vaccine coverage, because we're still waiting for lab results for the other parameters. This is the city of Goma. Those are the COV campaign vaccinations in 2019 and 2020. The strategy was to vaccinate the city in several times, dividing into small areas, prioritized based on the reporting of suspected cases. High administrative vaccination coverage of 90%. 2-3 years after the campaign, we did a survey. The city was divided into 8 areas, and the vaccination coverage was lower than we expected this time. The overall vaccination coverage in the city was 45% and barely 50% in the areas that had been targeted for vaccination. Those results show that the partial vaccination strategy in several campaigns finally diluted the vaccination coverage in the city. Also because of major population movements that might have played a role in addition to this patchy vaccination coverage. Now, we've had 2 major epidemics over the last months. Nana mentioned that. Those epidemics were at the edge of the town in camps for displaced people. There was a degradation in the security situation, and the people in those camps had not been targeted by the vaccination campaigns in 19 and 22. So far, we've included more than 8,000 suspected cases of cholera. Most were not vaccinated. Increase in RDT positivity, 37% in 2021 versus 56% in 2022. Here is the reported case incidence with a positive result to the RDT in various parts of the town. And since the beginning of the study, we excluded people who declared themselves as being displaced people during the epidemics I mentioned. Cases are spread out throughout the city with a concentration at the edge of the city and around the treatment centers, but there is no difference between the areas where we vaccinated and those that hadn't been vaccinated. This is Bukama, a rural area. The Congo River runs through it. You see the health area targeted for vaccination in 2022. All the health areas were not targeted, but a major of that, they were close to each other. And for this campaign, the administrative coverage was very high. Following this campaign, we did a coverage survey. We used a community-based methodology. As you can see on the map, here we've reported high coverage rates throughout the area, between 78 to above 90%, and pretty homogeneous throughout the area. We noted that the villages that reported the highest coverage rates were also those that had adapted their distribution strategy to what people have to do during the day, like if they have to go to work to the fields. A cholera epidemic appeared in Bukama area shortly after we opened the activity, and as soon as the rainy season began, so the COV vaccination took place at that time because it had been planned before, and we've seen a decrease in the number of cases. Alerts are stable, reports. Throughout the 22-23 rainy season, it remained really stable and quiet. We've included over 1,000 suspected cases with a profile that changed over time. Before vaccination, more than 60% RDT positive versus only 31% since we started vaccination. On this map, you have the number of reported cases that were positive to the RDT since the second vaccination campaign in 22. The cases were reported mainly in the health areas along the Congo River. They were the ones who reported the highest number of cases and that were targeted by vaccination. So vaccination did not totally eliminate the cholera in the area. We continue investigating that and following it up. Now, differences between the two study sites. First, in terms of context and population. On the one hand, you have an urban site with lots of population movement. In the other site, it's a rural population, more logistics constraints. The COV vaccination campaigns differed. In Goma, we vaccinated in several slots with a prioritization strategy, whereas in Bukama, a single campaign was conducted in a population that was cholera oral vaccine naive. They had never been vaccinated. And the two sites show different dynamics when it comes to the reporting of cases. We also analyzed the risk factors, the risk factor for having an RDT positive result with logistic regression. One of the way cholera is transmitted, it's well known, is water. And we can see differences between both sites. Drinking surface water in Goma appears as a risk factor, whereas in Bukama it protects you to drink surface water, and it's the opposite for the public distribution system. We may assume that keeping up the quality of the water in the public distribution system is a headache in rural areas like Bukama. And the geography can also play a role for surface water. In Goma, water is often delivered by tanks. It appears as a risk factor. Water supply is quite a complex exercise in Goma. On the basis of those preliminary results, we can point out some elements that are noteworthy for vaccination campaign strategies. It's difficult to vaccinate partially only in a city with population movement, and distribution strategies are better suited for rural areas. It shows possible differences between two sites, but both are cholera endemic. But we can support control operational strategies that are adapted to the context. Here I only have part of the surveillance results, but this is a multi-activity project, and we'll be able to compare several types of data that will eventually give us an overall view of cholera transmission in Africa in the context of vaccination campaigns, and this might help us to design preventive vaccination campaign strategies. And of course, we'll have to take into account the difference between the various endemic sites. Thank you for your attention, and soon we'll come back with more results on the projects. I'd like to thank all the team members and our partners, particularly the Congolese Ministry of Health, the Pasteur Institute, and the Wellcome Trust in particular. Thank you.